You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 9th, 2022. This week, a potential new anticoagulant, surveillance stress testing, a trial misinterpretation in a major journal, an old diuretic makes a comeback, and artificial intelligence in cardiology. So first up, factor XI inhibitors. Now, the benefit of anticoagulation is that it reduces clot formation, and this decreases clinical events like stroke. But the harm of anticoagulation is that it reduces clot formation, and this increases the risk of bleeding. And perhaps because it is unseen, it's easy to forget that our clotting system is like this elaborate dance or balancing act. Perturbing this balance with anticoagulants can be beneficial, but it is surely precarious. The factor XIa inhibitors are supposed to be like the Goldilocks anticoagulants. Now here's how the hope works. Factor XI is involved in clot amplification once an injury occurs, but activated factor XI has only a minor effect on clot consolidation during hemostasis. Now the observation dating back a long time, years, that individuals with deficiency of factor XI, so-called hemophilia C, have apparent protection against ischemic events such as stroke, but low rates of spontaneous bleeding. And this has led to development of a new class of drugs called factor XIa inhibitors, which prevent the activation of factor XI. And there are actually multiple forms of drugs that can do that. At ESC, I actually had a video interview with Dr. Eichelboom from Hamilton, and that's not up yet, but look for that coming soon. The obvious goal would be to reduce thrombotic events in the coronaries, in the brain, without the Achilles heel of typical oral anticoagulation, that is bleeding. At the ACC meeting in the spring, we heard results of the phase 2 study called Pacific AF, in which the small molecule factor XIa inhibitor called asundexian resulted in numerically lower rates of bleeding compared with apixaban. And at ESC, three hotline trials presented early data on factor XIa inhibitors. Now, this podcast rarely discusses phase 2 trials, but given the massive potential of this class of drugs and their placement in the hotlines at ESC, I will give them some brief comments. Now, one trial was called Pacific MI. It was led by the Duke team, first author Sunil Rao. They randomized about 1,600 patients with a recent MI in a phase 2 dose-ranging study. There were 4 arms, and all 4 arms included dual antiplatelet therapy with aspirin plus a P2Y12 inhibitor. The small molecule inhibitor tested was asundexian. Arm 1 had 10 milligrams, arm 2, 20 milligrams, a third arm, 50 milligrams, and a fourth arm was placebo, plus DAP. The primary safety endpoint was bleeding. The primary efficacy endpoint was major adverse cardiac events, or MACE, and there were 3 main findings. There was a dose-dependent inhibition of factor XIa activity. The 50 milligram dose resulted in more than 90% reduction in factor XI activity. Over about a year follow-up, there was no increase in major bleeding relative to placebo, but there was also no signal of reduction of thrombotic events. Now, recall that this is a phase 2 study. These are mostly used for dose ranging and safety. They don't recruit enough patients to power for hard clinical endpoints. Now, in this pooled asundexian arm, for instance, there were 1,200 patients, but in a similar trial that was a phase 3 trial like COMPASS, there were more than 9,000 patients per arm. The authors concluded rightly, I think, that further study of the factor XIa inhibitor asundexian inadequately sized phase 3 studies for patients following an acute MI is warranted. Now, Sanduxian was also studied as secondary prevention after stroke in the Pacific Stroke Study, and it had a similar methodology, about 450 patients in placebo, 10 milligram, 20 milligram, and 50 milligram arms, and the primary efficacy outcome was ischemic stroke or covert infarct on MRI at 6 months. And in Pacific Stroke, there were no significant differences in the event rates of the primary outcome. More worrisome, there was no dose response noted either. Now, in a post hoc exploratory outcome of recurrent stroke or TIA, there looked to be a dose response with events lowest in the 50 milligram dose. And in an exploratory post hoc subgroup, patients with atherosclerosis had fewer recurrent strokes or TIAs in the 50 milligram versus placebo arm. Bleeding rates in Pacific Stroke trended higher with the Sanduxian but did not reach statistical significance. The authors called these results promising and said that it required validation in adequately powered phase 3 trials, which are trials powered to detect differences in clinical outcomes. Now, also at ESC, we heard results of another phase 2 dose-finding study of another small molecule oral factor 11A inhibitor called milvexian. And again, there's multiple factor 11A inhibitors. This trial was called Axiomatic SSP. And again, the methodologies were similar and the results were similar. There was no dose response seen for efficacy, though each milvexian dose had lower rates of the primary outcome except the highest dose versus placebo. And there were numerical increases in major bleeding at milvexian doses of 50 milligrams BID and above. The majority of these were GI bleeds. I want to reiterate that all of these studies are phase 2 studies or dose-ranging studies. There's some promising signals. This class of drugs is going to go to phase 3 trials. It's super exciting because it's a brand new class of anticoagulants that may offer similar efficacy and better safety, and that would be a huge development. I'm also excited that our hospital, Baptist Health Louisville, will be a center for the phase 3 Oceanic AFib trial comparing apixaban to a Sanduxian for stroke prevention in patients with AFib. Okay, second topic, surveillance stress testing. Now, last week, I told you about a unique screening program for cardiac disease that held great promise called DANCAVAS. Well, doing stress tests in asymptomatic people after revascularization is sort of similar. The idea is to pick up disease and intervene on it before it causes problems. And for the first 3/4 of my 26 years in practice, stress testing after bypass or PCI was routine. This was a therapeutic fashion, if you will, and it didn't hurt that stress tests, especially those with imaging, are basically money-printing machines for cardiology offices. Now, with the advent of drug-eluting stents, the less restenosis, and then the Courage and Berry 2D trials, which found no added benefit to revascularization over optimal medical therapy in stable patients, routine cardiac stress testing declined after PCI and revascularization, but it did not stop. And even the most recent guidelines allow a 2B recommendation for image-based stress testing may be considered in high-risk patients. Now, of course, high risk is in the eye of the beholder. At the ESC meeting, we learned the results of the post-PCI trial, which also made it into the New England Journal of Medicine. Now, post-PCI trial, as first author Duck Woo Park randomized about 1,700 patients in South Korea with high-risk PCI, either by anatomy or clinical characteristics, to a follow-up strategy of routine functional stress testing at 1 year after the PCI or to standard care alone. The primary outcome was death, MI, or unstable angina, so these were hard clinical outcomes. The enrolled patients were definitely high risk. 1 in 5 had left main PCI, slightly less than half had bifurcation disease, 70% had multivessel disease and or diffuse long lesions. Okay, here are the results. At 2 years, the primary outcome occurred in 5.5% of the stress testing arm versus 6.0% in the standard care arm. This 0.5% absolute risk decrease and 10% relative risk decrease did not meet statistical significance. So we can declare this a negative trial and the end of the foolishness of post-revascularization stress testing, right? Well, sadly, it's more complicated. And what follows, what I'm going to tell you, is a super important concept in trial interpretation. Now, the clue to the problem, the complication here, comes when you look at the confidence intervals surrounding the hazard ratio or the relative risk reduction. The point estimate of the hazard ratio is 0.90. That's a 10% relative risk reduction. Now, that's not big, but recall that last week the Dankavas trial nearly met significance with a 5% reduction in the hazard ratio. In the post-PCI trial, the hazard ratio of 0.90 had confidence intervals ranging from 0.61 to 1.35. Okay, what do all those numbers mean? Roughly, it means that if you were to repeat this experiment an infinite number of times, there's about a 95% chance that post-PCI stress testing results in an effect size that ranges from a 39% reduction in MACE to a 35% risk increase in MACE. My friends, this is a terrible outcome of a trial. The outcome is inconclusive. All that money and experimentation yielded a result that tells us little. Why did this happen? Well, it gets to the tension between having enough patients in a trial to detect signal from noise and paying for trial, which is expensive. The authors write in the paper that they powered their trial based on assumptions, and one was that they wanted to detect a 30% reduction in the primary outcome. 30%! That's a huge difference from just a stress test. They also estimated a 15% rate of events in the control arm. But in reality, in the trial, there were only a 6% rate of major adverse cardiac outcomes. These two assumptions led to enrolling not enough patients to detect differences, and the wide confidence intervals ranging from a huge benefit from post-PCI stress testing to substantial harm from post-PCI stress testing. Now, the authors wrote one sentence in the New England Journal to explain it in the discussion section, and here it is, quote, "A 30% relative lower risk of a primary outcome event with active surveillance with stress testing than with standard care may be too ambitious with contemporary medical therapy." That's it. That's the only comment we get about the inconclusive nature of the trial. Now, they justify this assumption by saying data were scant at the time the trial was planned. They cite in their paper two trials, PROMISE, which was functional stress testing versus CCTA in patients with chest pain, and the Factor 64 trial, which looked at screening CTA for MACE reduction in diabetics. Both of these trials were powered to assess a 20 to 40% reduction in events, but both reported no significant differences, so they were null trials. Well, here's the problem. A reader of the New England Journal of Medicine might just focus on the conclusion, which read, quote, "Among high-risk patients who had undergone PCI, a follow-up strategy of routine functional testing, as compared with standard care alone, did not improve clinical outcomes at 2 years." This is misleading, if not a totally wrong conclusion. A better conclusion would be, among higher-risk patients who had undergone PCI, we could not determine the efficacy of a follow-up strategy of routine functional testing as compared with standard care alone. Now, then in the discussion section, the authors could explain their decision on how many patients to enroll and what the spread of the confidence intervals actually mean. What is also weird is that the chosen editorialist missed this issue. She did not mention the wide spread of the confidence intervals and the inconclusiveness of the results. And she wrote, quote, "The post-PCI trial provides compelling new evidence for a future Class 3 recommendation for routine surveillance testing after PCI." I don't think it does. Now, my gut tells me that stress testing after PCI probably provides only benefit to the cardiologist and hospitals, not to the patients. This trial does not strengthen or weaken that gut feeling. My prior belief or gut feeling is informed by oodles of trials of patients with stable ischemic disease, such as Courage, Berry 2D, and now ischemia. All the available data tell us that intervening on asymptomatic disease when patients are on optimal medical therapy adds no benefit. In post-PCI trial, there was a higher rate of intervention in the testing arm, And my priors would lead me to believe this would not benefit these patients even though they are at high risk. But again, my friends, the lower bound of the confidence interval went to 0.61. That's a potential 39% benefit. But it also went to a 35% risk increase. So we don't know, and that is sad. Okay, third topic is the ADVOR trial. Maybe it is my age, but I love trials that show old therapies work for common problems. Also, that I'm a retired cyclocross racer, and the ADVOR study group hails from Belgium, the crucible of cyclocross, only intensifies my interest in this trial. First author, Wilfried Mullins. Now, patients who present with acute decompensated heart failure need aggressive action, mainly aggressive diuresis. And we've known for a decade or more that high-dose loop diuretics are the best option. But these don't always work to decongest the congestion, especially in patients who are already on diuretics or, say, have kidney issues. The ADVOR trial randomized about 500 patients with acute heart failure to one group had loop diuretics plus IV acetazolamide, or the other group, loop diuretics alone. Now, acetazolamide is a carbonic anhydrase inhibitor that reduces sodium reabsorption in the proximal tubule. The drug is old as dirt. It's been used for altitude sickness and glaucoma and been around forever. The investigators measured successful decongestion, defined as the absence of signs of volume overload within 3 days after randomization and without an indication for escalation of decongestive therapy. And the results, successful decongestion occurred in 42% in the acetazolamide group and in 30% in the placebo group. The risk ratio was 1.46, so 46% better in the acetazolamide group, and the confidence intervals went from a 17% improvement to an 82% improvement, which was highly statistically significant. The duration of hospitalization was better by a day in the acetazolamide group. Of course, the ADVOR trial was not powered for clinical outcomes, and there were no statistically significant differences in these outcomes. There were also no significant differences in safety outcomes. Now, my comments are that these are actionable results. Acetazolamide cost almost nothing, and it helped. There were no safety signals. There was abrupt and rapid diuresis is important in these patients. Now, Table 1 of trials is always important. Table 1 is the patient characteristics. These were 78-year-old patients already on loop diuretics who had big BNP levels and advanced heart failure, often with mild chronic kidney disease. These were not low-risk diuretic naive patients, so let's not go overboard. And another topic about this and the discussion that came up at ESC is applying ADVOR trial results in the era of SGLT2 inhibitors. I don't quite understand the discussion. While I see benefit of SGLT2 inhibitors, especially in patients with heart failure with reduced ejection fraction, I'm not sure an oral drug is going to have an immediate impact over the first 3 days. I mean, oral drugs are often ineffective when there is congestion because it can affect GI absorption. Now remember, these are patients who are struggling with acute congestion. The emphasis here on acute. IV acetazolamide helps get them acutely decongested. You can use it for a few days. You can get the patient out of the hole they're in and then start SGLT2 inhibitors who have heart failure with reduced ejection fraction. What's more, I understand SGLT2 inhibitors as much milder diuretic agents than acetazolamide, and nephrologists can correct me here if I'm wrong. What I would like to ask the Belgian trialist is how they got this idea. I mean, acetazolamide has been around forever. How come no one thought of this for the last 20 years? Anyways, I want to say proficiat to the trialist. I look forward to trying this strategy myself. Next topic, final topic, artificial intelligence and cardiology. At ESC, we heard the results of the first blinded RCT of AI in cardiology. Dr. David Ouyang from Cedars-Sinai presented results of the EchoNet RCT. This was a blinded, randomized controlled trial of sonographer versus AI assessment of left ventricular ejection fraction. Now, some brief comments before I tell you about this very interesting and yet unpublished trial. One of the most common questions in all of cardiology is cardiac function. Knowing the strength of the heart contraction is the key risk stratifier in many decisions in cardiology. But accurate assessment of EF is one of cardiology's biggest secrets. Here's the truth. EF assessment varies a lot. Some of the variability is because of pre and after load, say the patient is excited or volume depleted. The ejection fraction can vary on a Monday versus a Tuesday. But ejection fraction can also vary based on human characteristics. A sonographer typically traces the outline of the heart in diastole and traces it in systole, and a computer calculates the difference, and if their heart's got a lot of squeeze, it means there's a high ejection fraction. Now, back in the day when they let me, electrophysiologists, read echoes, we would visually estimate the ejection fraction. We would say, well, that looks a little sluggish, EF 40%, or that looks a lot off, 25%. And I'll sit down for this. That still happens today. The sonographer does the planimetry, the tracing, and the preliminary report outputs an ejection fraction. Then a cardiologist overreads it, and she or he simply say, I agree or don't agree. Often when they don't agree, it's because it looks more or less vigorous. I often feel like it's a bit like judges who give tougher sentences right before lunch. There's a lot of play in this. Now, back at Indiana University, when I trained in the 90s, Harvey Feigenbaum would not allow us to put a number on an EF. We had 4 categories at IU: normal, mild, moderate, and severe LV dysfunction. So I hope to have convinced you that ejection fraction reading is ripe for non-human automation. The EchoNet trial was elegant in its simplicity. Now, echoes that had previously been used clinically at Cedars-Sinai in 2019 were then used in this study. The randomization was to compare sonographer assessment of ejection fraction or an AI assessment of ejection fraction. And again, this was the randomization. It was blinded. The AI program had been previously validated, and they published this in Nature. The final step in EchoNet was the blinded cardiologist overread, and the primary outcome was the proportion of studies in which the cardiologist changed the ejection fraction more than 5%. This trial had more than 3,700 echoes, and the results favored AI. The cardiologist changed the AI left ventricular ejection fraction reading in 17% of the echo images versus 27% for the sonographer-interpreted images. Now, this was not only non-inferior, but is also superior. Some other notes: cardiologists could not distinguish between AI and sonographer assessments. AI saved the sonographer 2 minutes. Now remember that they do about 20 echoes per day, so that's nearly an hour every day. AI saved the cardiologist some seconds in the reading. Now, some comments. This is a single center study. There was no comparison to MRI, which may be a more accurate assessment. EchoNet is the beginning, I think, the tip of the iceberg. You have to put on your future hat here. Remember that we could not imagine the internet before there was an internet. Now, although some may posit that AI can replace human readings, I think for the immediate term, or even for the next 5 to 10 years, I see artificial intelligence aiding human reading, not replacing it. Pattern recognition like echo reading and ECG reading are places where AI, I think, will help us. Dave Albert and his Cardia mobile device are doing great work with artificial intelligence in interpreting rhythm strips. The Mayo Clinic group is publishing great stuff with artificial intelligence and ECG reads. And so there is potential here. I say congratulations to the Cedars-Sinai team. Please tag me in the podcast when your paper comes out. And so that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, friends, if you like this podcast, please take the time to give us a rating. Write us even a 1 or 2 sentence review. These little tiny things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.